Shape, don't assign, and engineer early wins. So this is what, if open-ended interviews are what I'm most passionate about in the conversation stage, shaping up goals and having a difference between a right now goal and a terminal goal is what I'm most passionate about when it comes to behavior intervention, whether it's a caregiver or a client or anything in between. Heck, the supervisees. Oh, I didn't mean to do that. Here we go. When we write our behavior plans, we don't say client will do X terminal goal at 90% effectiveness for a month straight and then have nothing in between. We tackle prerequisite goals. We tackle shaping. An amazing, I think the best example of this is in the PFA and SBT process. This isn't unique to their process. Of course, shaping has been around forever, and so is this way of programming. But it's clearly laid out in SBT, where you start with these micro skills and you slowly build up the branch, right? CAB 1, CAB 2, CAB 2A, CAB 2B, CAB 2C, right? Linguistics aside, right, all it is a series of tiny goals that get you to the terminal goal. That's the same way we want to present goals to caregivers. We want to say, all right, what really moves the needle on your quality of life? Let's do our open-ended interview and really hear what you have to say. Once we know what they're looking for, well, what is the smushed down version that is feasible, that they're ready to implement with fidelity, and they're actually able to tackle? So we talked about toilet training at the beginning, right? Well, we probably don't want to say, all right, the first thing we're going to work on is your kid being 100% toilet trained. We probably want to start with, all right, the end result of what we're working on is toilet training. To start, the first thing I want us to focus on this week is going to be mans for bathroom, or it's going to be picture identification. It's going to be wet versus dry, whatever that, strategy is. Couple things people saying in chat: letting them vent increases trust. Nice to have someone acknowledge their pain. Yeah, I think that I think it's venting plus doing something about it. So like I always equate this to like staff training, right? If anybody's ever been a director, they've probably sent out a staff survey. And on that survey, it says list things that are not going well. And staff lists like 12 things. And then you receive that survey and you say, all right, thanks. And then nothing ever changes. That kind of crushes the relationship, right? Because if you're going to be asking what you can do to help, and then you get the answers, and then you don't do anything to help, well, there's no point in having that relationship, right? It just crushes that trust. So when it comes to letting caregivers vent, I just encourage you to also still keep it actionable when possible, right? So if they're venting about 3 different things, pull out one of those and say, oh, well, I think that's something we can really start to tackle. It probably is going to look like this, this, and this. Is that something that you want me to start brainstorming on with you next session, right? Just keep something actionable so you can say like, yes, we're moving to that. We're going in this direction versus just staying stuck in kind of a mental trap. ACT is really good there too. Present moment awareness versus previous events is something to consider as well. So we want to define the terminal behavior precisely. We want to analyze the implementation skill. We want to find the entry point. Where are they now? We want to create a sequence so we can maximize early reinforcement. And we want to use BST or a variation of BST depending on feasibility at each step. So focus on that task analysis and the entry point. We want to know where they are now, whether it be a skill, an amount of time they can commit to, anything in between, so that as we go from where they are now to a little bit further and a little bit further and a little bit further, we're not going way backwards or jumping way too far. Remember that shaping, the way shaping works is small steps at the beginning. So if you don't assess where they are now and you place the kid in underwear before they can identify what wet and dry is, well, you are in for a beating when it comes to the success of that program. We're going to skip through BST. I have hours of stuff on BST in the clubhouse. You all have listened to hours of how to do BST. Yes, it's fantastic. Yes, the most important factors are instruction and feedback. Yes, it can be effective over a variety of settings. Congratulations, you just relearned BST. Okay, sorry, one more thing. I don't think I put it in here, but Teachback is also a pretty valid strategy for caregiver training, especially with telehealth. I should have mentioned this before to Bahram. Teachback is actually founded in the medical field. It's when a doctor or a physician would come to your room and they would say, hey, we are going to do XYZ to your foot. It has these complications. This is what the procedure is going to be looking like. Do you want to repeat that so I assure you understand? And then the patient says, yeah, you're going to do this and this and this. And then the doctor says, exactly. Additionally, we're going to do this, this, and this. Does that make sense? Can you re-explain that? And basically you go back and forth until the patient has completely taught back the concept to the physician. Right. So that is called Teachback. It is behavioral analytic as well. There is research. I forget the exact publication on it. I think it was a Tyra Sellers article. I'm not sure. But it's a great way over telehealth to communicate that instruction phase, especially when the kid isn't present. I encourage you to be a little bit selfish with that first target. When you first set up the caregiver training and you talk about that first goal, you need to give yourself a softball, right? You need to serve it up on a silver platter and you need to knock that sucker out of the park. The best caregiver training goal to start with is one that is visibly improves quality of life for the caregiver and is accomplishable within like a week. Like in a perfect world, that's what it looks like. Because you say, do this, and your life will get better. They do it again, they do it a third time, and their life gets better, right? That's ideal there, right? Because you're reinforcing the process of listening to what you say and then getting the outcome that they want. As you progress in that alliance, you can grow from a 1 week target to a 3 week target to a month. Like you can grow your expectations, but at the beginning, the less on your side they are, the smaller that reinforcement should be. All right, barriers. When it comes to conversations about barriers, the short and long of it is you need to know what's actually happening. I do a lot of sales with my marketing agency. If you don't know, I also run a marketing agency. That's how I pay the bills while I'm able to provide CEUs for free. The marketing agency is for ABA companies if they're interested. So I do a lot of sales. And what happens in sales is you start a conversation with somebody and they tell you that, oh, well, they can't do this because of XYZ. And then you ask about XYZ and it turns out that it doesn't actually mean anything with XYZ. They just don't know if it'll actually work, or they don't know if XYZ. It usually comes down to some type of trust thing. And so your job as a salesperson is to work through those objections and get to the real root cause. And so that's what we want to be doing in caregiver training, not as a salesperson, but as a member of the alliance. You want to be able to work with that person and say, I hear that, you just don't think it's going to work, but I'm curious, can we dive deeper into that? Is there more to it? Are you seeing it not work? Oh, you're seeing it not work. When are you seeing it not work? You're seeing it not work when it's 6 p.m. and you're cooking dinner and the TV turns off and the power goes out and XYZ happens. Great. Let's talk about that scenario. What was happening there that isn't happening with what we usually see, right? And then you chop up variables and you can actually get to what's really happening. The other types of barriers are the caregivers thought something was feasible, but it actually isn't. This happens all the time in early intervention, right? The parent says, I cannot have this kid asking for my phone 24/7. That we have to solve that problem. And I say, okay, let's do XYZ. It will be challenging. This is what it will look like. Let's set this small goal. Is that possible? Yes, 100% I can do that. You come back a week later. This isn't working. I don't think this really matters, blah, blah, blah. What happened? Well, it turns out they're not working towards that goal because what they thought was feasible is not actually feasible. Sounds good. Shove that goal smaller. How can we make it more feasible? How can we change it? This is where creativity comes into play. This is, for all the research that we care about and all the research I read, you read and consume knowledge so that you can be creative in the future, so that it's not just a red green board that's going to accomplish this, but there's also shaping and signals and lag schedules and all of these fancy things that you can do, not just to show off, but so that you can design and implement a treatment package that actually works for that caregiver, right? Sorry, I'm skipping ahead so I make sure we cover the last one. Covered that. All right.